All right, thank you for having me today. And I have 10 minutes to tell you about some work that I've done with Redwood MedNet, HIE in Mendocino, really talking about using an HIE really as a community of care platform. So I'll give you kind of our insight there. I'm just assuming. So, and the first thing is I hope I can deliver some good news. It's just a prediction. I think HIEs are an obvious piece of infrastructure. The problem is that we don't have great adoption just yet. 20% of the doctors have EHRs. That's not a big part of the market. But once you're a doc with an EHR, do you really want to have faxed lab results and radiology results? Not really. You don't want a paper letter to come back as a result of a consultation with a colleague. So you want things electronically to flow into your EHR. You don't really want to write a prescription anymore. So these are obvious things that happen once you change the culture in a practice from being paper-based to electronic. You do that enough across the community, HIEs are an obvious thing. Why? Because of this. They're really inevitable. If you allow people to interconnect across all the nodes all I did was, this is actually a very common calculation for how many connections you need in a network to connect all the nodes together. And all I did was 100 practices and 6 labs saying that we need to interconnect them all. If you want to interconnect them all the way we do things today, and I used a cheap interface, that's $5,000. We get charged $10,000 to $15,000 from vendors. The result would be $27 million, okay, for 100 practices to connect them all that way. If you use a hub-like architecture, it's $500,000. So it's an obvious, HIEs, I don't have any trouble saying that they're going to be sustainable. I think it's a matter of adoption. Once we have enough adoption, HIEs are part of the landscape. So if that's the case, let's look ahead. So it's clear they're going to save us money. I think there was a Health Affairs article in 2005 that predicted that just on lab costs alone, for the labs that we do nationally today, about a third of the cost of the lab test itself is communication cost, meaning getting the order on paper and then reporting it back like we have to do. If we can reduce that down using HIEs as we're talking about today, you would have a $30 billion savings per year just on the labs alone. So there's going to be cost savings there. But what else can we do? Okay, it's going to save costs, but can we improve care? I think we can. So can we go beyond just sort of the lab exchange? And can we leverage HIEs to connect patients to services? Things like a wellness program. We have community care cancer resources. We have navigator programs. Translation services, at UC Davis, we're very fortunate. We have a great translation service, but that may not be the case across all the communities. Can we optimize clinical care using HIE traffic itself? And can we ultimately improve transitions of care? This is a big area of cost. And the key really for all this is to be able to identify patients with conditions, obviously with their consent, okay? But to be able to mine the HIE data stream looking for individuals who have specific conditions. That's how you're going to offer services. So that's the idea here. So with that in mind, I've been working with Redwood MedNet for a long time in a variety of roles, usually as an advisor. And so we kind of got together and we said, hey, can we do something like this within the Redwood MedNet HIE as a kind of an experiment? So the question is it possible to screen for COPD and smoking within the scope of a medical community using an HIE and to optimize the care these patients get? So that was the idea. Why COPD? Well, hopefully it's obvious, but the top bullet I just learned a couple of days ago. 1 out of 5 patients that have COPD that are taken care of using Medicare dollars actually get readmitted within 30 days of discharge. That's pretty high. That's a big cost. It's a progressive disease. It's widespread, and there's an average 7-year delay between the presentation of symptoms and the actual diagnosis of COPD. A lot of lung function can be lost there. And last but not least, 31% of COPD patients are not prescribed maintenance therapy. And if you go to the Duke, you look at some of the Duke data that Atul Gawande looked at, it's clear that across the country we have big variations in how we take care of patients. So we need to be able to deal with some of that and try to optimize the use of the healthcare dollar and optimize care. So One of the things that we did, we have two phases. Phase one was identifying optimal methods for identification of individuals with COPD. Later on, once we identify them, we plan to help in coordinating their care, understanding what's happening with them, and then also for those who are still smokers to offer them smoking intervention, smoking cessation as an intervention. The setting here is Redwood MedNet, about 10,000 basically messages per week of a variety of types. We analyzed that, looking for high-value messages, and we felt that CCDs would be of high value. They're summary of care documents, and I'll show you why you can't just diagnose COPD from lab data. It's one of those diseases that really doesn't lend itself to that. So we focused on CCDs. And so it's not simple to identify a smoker. We have a lot of criteria here. This is just a list of criteria that I came up with for the project. These are all things, ICD codes, CPT codes, pharmacy history, medication history, pulmonary lab testing, which I'll get to in a minute. Here's the gold criteria for COPD. This is the Global Initiative for Chronic Obstructive Lung Disease, well-known criteria for the different stages. So when you're going to triage somebody for appropriate treatment, you really need to classify the disease. This is the classification. This is the gold standard, no pun intended, classification. And you'll notice there it's pulmonary function test driven. Here are the problem lists and health claim kind of data. So these are all the ICD-9 CM codes. Some are consistent with COPD, some are suggestive of COPD. So you get into this idea of not everything is clear. Here's clinical narrative information. There is medication criteria. So medications that might be on, some are suggestive, some are definitive. Radiology report criteria, of course, this requires natural language processing unless radiology reports magically tomorrow are done in a structured way, maybe one day, but that's one of the challenges there. And then pulmonary function testing, hopefully that's, and consistent with COPD. So that's one of the key aspects of COPD diagnosis. So our preliminary observations was basically we had many challenges. So PFTs are not done in real, in actual clinical labs. They're done in the office. They're done by pulmonologists. They can be done in the hospital. So they're really not part of the HIE stream. So one of the key pieces of information to identify somebody's basically degree of COPD is really missing from the HIE stream in large part, unless it's in the CCD somewhere, in which case you might have to NLP, natural language, parse it out, which would not be ideal. Health claim data, with procedures are not part of the HIE stream usually, so we couldn't determine whether PFDs were performed. There's also limited exchange of clinical encounter data using CCD. We like to talk a lot about it, but if you actually look at HIE traffic today, see what percentage of that are actually CCDs versus lab and radiology and other kinds of things that are all valuable for decreasing lab costs, but when it comes to this, they may not be actually as helpful. And then smoking history is generally not in structured format. We hope meaningful use criteria will change that, and I think you'll see a lot of vendors changing that. But will it end up in the CCD in structured format or in some message? That's another thing altogether. I don't think meaningful use says you have to put it in structured format in all the messages. You do have to collect it in a structured way. And then we also looked at maybe there's another source of information. So we looked at Clinical Data Repository, which turned out had all this data. And then there's additional criteria here that I'll just go through here. It's not moving. Okay. Yeah. All right. There's a delay.
Do you need technical support?
I think I need tech support.
Regional Extension Center, where are you?
All right. All right. So I'll just cut to the chase here. So we found patients with a common disorder like COPD may be difficult to identify with today's even summary of care, which is kind of the gold standard in the HIE exchange in terms of value of data. They're not really that standard when you look at them. They're done differently, and they're not that prevalent. So hopefully that changes. Prevailing other HIE traffic is also not optimal. Where the heck are those PFTs? They're not in there. So we felt really until data in flight is more standard, it was better to access the clinical data repository. So we approached the partner that we're working with about accessing their clinical data repository. And so there's this idea that maybe we should also think about virtualized clinical data repositories. It may sound scary to many, but aggregating data across a geographic community in terms of this kind of thing may have a lot of value. And a lot of the high-value data will be in the clinical data repository. And so, what about that? Does everybody have a clinical data repository? Well, if you look, those that have EHRs that are medium to large groups will almost always have some form of clinical data repository. Most of them do. You can leverage existing relationships that the HIE has with these organizations to then access the clinical data repository if they're willing. And then you can also convert or transform the CDR data into CCDs, which is something we're experimenting with, as a kind of a standardized information packet for something like COPD. So this is kind of where we're going with that. And then I'll close with this slide. This was a article, a small, brief article, a report really, came out of the New England Journal of Medicine this week. And I'm proud to say Chris Longhurst, the middle author, is actually a graduate from our Health Informatics program at UC Davis. He's the CMIO at Stanford. And this is the first case of an actual use, published case, of using an existing clinical data repository to then help inform you when you're going to take care of a patient with a very unusual circumstance. So this was a 13-year-old girl with systemic lupus who also had nephrotic syndrome from the lupus. It had damaged her kidneys. And she was acutely ill with pancreatitis. And she had a positive antiphospholipid antibody. All these things make you very high risk for getting a clot. And so the question was, should we anticoagulate her up front, preventively, instead of waiting for the clot? Because that would really complicate things. There are no studies on this kind of situation at all. So Stanford has Stride, which is a clinical data repository they've had for a while. I think it has about 3 to 4 million records. And they queried Stride, and they found 98 patients with systemic lupus in the pediatric population within a number of years. And after 4 hours of querying and doing some pretty basic analysis with a statistical tool, they found that the SLE patients that they had, or that were in the same situation, clearly showed that if you had pancreatitis, you were almost 12 times more likely to get a thrombus. And if you had nephrotic syndrome, you had almost 15 times the risk of getting a thrombus. So they decided to anticoagulate. I mean, this was clearly a use of a data repository for clinical care. So this is the first time I think this has been done, but I think you're going to start seeing this. And I call this, rather than patients like me, this is patients like mine. So I think it's going to be a pretty interesting use of this kind of data. So we're experimenting with this sort of idea of going into the clinical data repository. We found the HIE data exchange is not rich enough for identifying certain disorders, particularly COPD, and then doing interventions. We think there's a lot of value to doing this kind of thing and offering services to the physicians as well as perhaps eventually patients directly who sign up for this and have PHRs perhaps. And then I think the future, once we move beyond sort of the lab exchange savings, is really trying to optimize clinical care. And I think we have a ways to go. And some of the challenges we're dealing with are lack of structure, non-coding, lack of data in the messages and that kind of thing, because the messages aren't really focused on optimizing care. They're focused on provisioning care, the process of care, as opposed to optimizing the care. So just sort of a FYI. Thank you very much.